It is embarrassing that healthcare does not assess its quality with the same rigor as other industries. The previous post, Guns, Van Halen, and Brown M&M's Real-Time Quality Checks, discussed the use of fictional data in standard workflows as a means to continuously check the quality of different systems, from areas as diverse from airport security, agriculture, and aviation. In this post, the summary is that we're going to look at two types of quality. Upper limit quality, which is the quality you assess under a simulation or under direct observation, and lower limit quality, which is the actual day-to-day variation in quality when the system doesn't know that it's being observed. And I'm going to suggest that medicine is only assessing the upper limit quality. And this is a problem because we don't actually know the day-to-day variation in outcomes. And we'll look at some examples on how you could potentially use fictitious data to assess this in medicine, and how in the long run this will actually create much better systems and better ways to train clinicians in real time. So let's turn to this first part on the two types of quality. As I mentioned, there's an upper limit of quality, which is simulated quality or observational quality, and then there's lower limit quality, which is real life quality. And the simulated quality, the problem is that because the system knows it's under a test, you're really assessing, usually under a simulated environment or under theoretically optimal conditions, how a system's going to perform. And from my opinion, this doesn't tell you anything about the day-to-day quality of that system. It's just setting an upper limit threshold. The second is the lower limit quality, and this is the day-to-day quality, and you can measure this two ways. One, you can measure it under typical average day-to-day variation, and this is what's going to tell you how the system's actually doing. For instance, in the example yesterday where we were talking about X-ray scanner operators in airports and the different threat image projection systems which put fake guns into real people's luggage on the screen to see if the people watching the screen are paying attention. Those types of systems tell you data you're interested in. How well do people perform on average during the week, in the morning, when they're tired, when they're hungover? And this is much more useful data than knowing how someone performed on a test 10 years ago, let's say. In a similar way, you can also observe this lower limit quality assessments or these real life quality assessments when a system is under stress. And so if you observe a system when it's being stretched to the limit, you're able to see, in these cases, how does it perform? Some of its operations may actually become quite dangerous and quite risky when it tries to perform it when stretched to the limit. And it might be better to add specific resources into the system in these cases to fill these dangerous areas, or it may be better to actually prohibit a system from performing certain functions at times of stress because it's too dangerous for them to execute those functions safely. Let's turn now to think about how this applies to medicine. In medicine, from what I can tell, we really are studying upper limit quality. For instance, physicians will have to write an exam, and this will tell you that based on textbook knowledge in a simulated environment, this is how these physicians practice. And it doesn't really tell you, in my opinion, their day-to-day quality that they provide. In a similar way, hospitals and medical schools undergo accreditation. And again, this is a fake condition. These institutions spend enormous sums of money and years preparing for these infrequent assessments. And again, it's not really telling you in real time the day-to-day variation in care quality. These types of upper limit quality assessments are fine to help identify those individuals and those institutions that even when studied under allegedly optimal conditions still produce a red flag. But we have to be clear what we're actually assessing here. We are setting a low bar. We're making sure that these individuals and institutions pass, and we're studying them to see if they can meet this low bar under, quote, optimal conditions, right? Because they're aware that there's an evaluation. And I don't really think this is sufficient. Would you trust the quality of a production line that was only certified under fake conditions once? Or would you trust the production line if it only had the quality of its output inspected once every several years? That's just crazy. I mean, factories go to enormous lengths and spend great sums of money to create real quality assessments that try to operate as much in real time and direct their feedback into the production system so they can fine-tune their output. And that's because these factories and just standard production systems have a specific tolerance of variability that they're going to accept, and they're aware of what their target is, and they make sure they don't deviate from it. In my opinion, I don't think healthcare either knows what its tolerance for variability is, nor do we know when we deviate from it. Let's actually turn to looking at some concrete examples now in medicine. I think one area to look at is, for instance, pathology. So pathology labs must conform to national certification standards. And these labs will be routinely sent audit samples, and an audit sample will come into the lab and it will go through the lab's normal processing and then be signed out by the pathologist with a final diagnosis. And the audit samples then will be pooled from across the country. All the labs will have received the same type of sample, and whichever report answer the most labs produced will essentially be what's considered the gold standard, the correct report, and then how people responded based on their report to this kind of gold standard will be how they performed on their assessment. And this is good. This is actually at least providing a semi-regular, semi-real life experiments and evaluations of pathology labs. But again, we have to remember this is only an upper level quality assessment. The lab knows that it's getting an audit specimen, and it's going to therefore be more careful when it prepares the specimen. It's going to put in more thought into the diagnosis. And again, this is good. It's going to catch a grossly incompetent lab process, which can't handle specimens under optimal conditions, but it doesn't really tell you what the day-to-day variation is in the busy lab. Another example are blood labs. And from what I can tell, blood labs, similar to pathology, these lab directors get it. They know the language of quality, of variation, of process, of systems, and critically, they genuinely care about this. And there are multiple lab certification bodies. They all have different standards to meet. They often require labs to run quality checks, sometimes multiple times a day. It's all very standardized. It's not perfect. Clearly, some labs are better than others in terms of quality, and particularly on specialized tests. But generally, as a sector, I find lab medicine, pathology, these to be light years ahead of clinical medicine. So let's look at some examples very quickly here on potential ways which you could use fictitious data to help evaluate the lower limit, the day-to-day variation in the quality of medicine, the actual real quality of medicine provided when the system doesn't know it's being observed. Well, one of the big ones which comes to mind looking at other industries is that of mystery shoppers. Mystery shoppers, mystery diners, secret hotel guests, these are all common within the hospitality and service industries. There's sets of regulations and ethics around this, and this is an established way to assess these businesses in real operating conditions. Often the groups which are doing these assessments are third parties, and they provide ratings and evaluations, or in some cases awards such as Michelin. One could also think of using the similar concepts such as mystery patients. And we have to remember that these patients don't necessarily need to be actors. They could be potentially real people with real conditions, and they would go through their real care process, but the only difference is that they would be able to gather much of the same undercover real-time quality data as a secret shopper or a mystery diner. You could also think of applying the same types of concepts to electronic consultation or e-consultation, which is becoming very popular. This is when a synopsis of a patient's file is sent digitally to another consultant for an opinion. These files potentially could be flagged or part of different mystery patient records, and so the receiving clinician wouldn't actually know that they're assessing a file which is going to be part of a longitudinal evaluation. And so again, it's a way to get an objective understanding on how people are performing in the real world. Now, one of the concerns is that it's difficult to directly insert fictitious data into healthcare. For instance, unlike other industries where we could just make up numbers and send them downstream, it's a bit harder to make up lab work for a patient or to make up an imaging report and see what people do for it. But I think there's a way where you could have a list of, let's say, laboratory results or a list of radiology results, which often are misinterpreted by the receiving clinician. And when a lab or when a radiology group produces a report, and this is a report on a real patient with their real result, that matches one of these patterns of labs and imaging, which is often misinterpreted, that patient's report could be secretly flagged. And then that report could go back into the normal process and the receiving physician would receive the report as they normally would. But the difference is that the system would have a process where they would follow up to find out what happened. Did the patient get the timely referral they probably required? Did they get their repeat imaging at the interval that was likely essential? Did these reports just get filed and not even acknowledged properly? And how long did it take for the physician to act upon the results they received? And so, although it's probably difficult to insert directly fictitious data into healthcare, you could probably, as we've mentioned here, identify patterns of data which are often erroneously interpreted and follow that downstream. Another example is in radiology, where you might take particular imaging sequences which have been the result in the past of malpractice lawsuits and make sure that those enter into circulation among the radiologists' work lists. And of course, we'd have to make sure that it's not obvious that these are fake patients. You'd have to have a very large repertoire of these malpractice suits. You'd have to track to make sure that individual clinicians don't receive the same fake or the same malpractice imaging read on multiple occasions. But you can imagine being able to create a system where you can help expose radiologists to key studies that have in the past resulted in error. Now, of course, this becomes more complicated because often when a radiologist does read a critical result, they would then typically phone the referring physician, and you run into issues of you'd have to have a referring physician and a referring phone number, which are in some ways fictitious, but it's not obvious to the person who's reading the result that this is a fictitious set, or else they would obviously interpret this scan with a lot more attention and detail than they may typically. And just one last one, which is on a slightly different path, but that's on the black box recording. And my understanding is that colonoscopies have an accepted standard on how long they should take. If you go faster than the accepted standard, the worry is that you might miss something. But from what I've seen, that the physician will stop and start their clock based on their own stopping and starting, and they document this on their own. And so one wonders why all colonoscopies, for instance, aren't video recorded as the default. And this would not only create a great imaging set for machine learning to read off of, but also provide objective evidence on the quality of the colonoscopy. And one could even then take that tape and have it perhaps reviewed for a second opinion. And so there are definite ways which we can move away from just measuring the upper limit quality in medicine to try to really understand the lower limit quality, the day-to-day variation of the system under regular operating conditions and the day-to-day variation of the system under extreme stress. Now, you can obviously think of lots of criticisms. Many people will say the care in healthcare is already fine, there's nothing to be worried about, that the system is stretched to the limit, and inserting, having clinicians perform activities which don't directly treat patients is a waste of their time. This post isn't going to be a rebuttal to all those arguments. I think there's excellent rebuttals to all of them. I think the key thing, though, to realize is that we have traditionally only been assessing upper limit quality, and we don't really know about the dark secret of where our lower limit is. This post doesn't really get into the idea of performance metrics, for instance, the number of patients that were operated on that had complications, or the number of patients who returned to hospital after discharge for heart failure within 30 days. Performance metrics are really hard to compare between physician and patient populations, and they're slightly different than what we were trying to get at in today's post on real-time data and the use of potential fictitious cases to assess real-time quality. Where does all this go? I think it's really exciting when you think about opportunities for the future of electronic health records. You can imagine real-time education being delivered through the electronic healthcare record. For instance, a set of results could be presented to the clinician, and then the EHR could ask the clinician, well, what do you want to do? Or the system could observe what the clinician does with the results that they're presented. And then the medical record could help guide and provide alternative suggestions, alternative advice. And so this is great to help train doctors and to keep old doctors' skills fresh. It's particularly useful in low-resource environments. You could imagine a great synergy where EKG is presented, the physician assesses it, the computer then asks, did you not see the T-wave inversions? And now your electronic medical record has become a personal lifelong tutor. It's always improving its skill, and it's always in turn improving your skill as a clinician. And I think this is really the synergy where we might be going in the long run with this type of ability to do real-time quality variation assessments.